All right. Well, my name is Lisa, and I'll be your MC today. I work at UC San Diego in neuroscience in the Parkinson and Other Movement Disorder Center. I'm a geriatric care manager. I run some of our education and outreach programming, so we may have met before. And I'm also a former caregiver to a loved one with Lewy body dementia. So today's purpose and event is extra close to my heart. So before we jump into the presentations, I wanted to go over a few housekeeping items and also go over our agenda. Figure out how to progress. Okay. So a few things to note. Today's session will be recorded, so the presentations aside from the film will be available to you. I can send an email out to all of the people registered with a link to the video in about a week or so. We'll also have time for questions after each presentation and also after the film. So for that, we're going to use the Q&A feature. So if everyone could take just a minute to locate that button on your screen, it's the two little question bubbles or conversation bubbles at the bottom of your screen. So we will do our best to get to all of your questions. Check chat here. Okay. So today's agenda, we will start with Dr. Litvin sharing about major clinical features of Lewy body dementia. And then we'll have questions. Next up, we'll have Dr. Galasco share. I found this on the web. Oh dear. My Siri is talking to me. Dr. Galasco will share how we make the diagnosis, and Dr. Legere will follow up with LBD treatment options. In the second hour, we will stream the Spark movie. It's the Robin Williams and his battle with Lewy body dementia, and that was created by the Lewy body dementia association with sponsorship from Acadia Pharmaceuticals. And then we will end with 15 minutes of Q&A for all of our speakers, and just do some wrap up for today. So our speakers are physicians at UC San Diego, and UC San Diego is a Lewy Body Research Center of Excellence. And this is a designation awarded by the Lewy Body Dementia Association for centers that meet a certain level of criteria that can deliver advanced diagnosis and treatment for those with Lewy body dementia. So our Research Center of Excellence is actually two subspecialty clinics. So these are both neurology centers with additional expertise in certain diagnoses. So the two centers are the Brain Health and Memory Disorder Center and the Parkinson's and Other Movement Disorder Center. Now, if you do not live near the San Diego area and are looking for a Center of Excellence for Lewy body dementia, a full listing is available on the Lewy Body Dementia Association website, and that's lbda.org or a quick Google. All right, without further ado, I'd like to introduce our first speaker, Dr. Irene Litvan, who is the director of our Parkinson and Other Movement Disorder Center. She has over 30 years of experience and has played a pivotal role in improving the management of Parkinsonism and dementia disorders. All right, you're ready to go.
Thank you, Lisa. It is a major pleasure to be with all of you and discuss the major clinical features of Lewy body dementia and a little bit about the clinical criteria. We are very happy to be able to be a center of excellence and to provide the best care possible to our patients. Sorry. I don't know what happens here. Okay, so why does it matter to discuss what we're discussing today? Well, it is extremely important because Lewy body dementia is dementia with Lewy bodies and Parkinson's disease dementia, and both of them are very common. Dementia with Lewy bodies is the second most frequent dementia following Alzheimer's, and it is estimated that there are 1.4 million persons with Lewy body dementia in the United States. It is approximately 4% of incidence and prevalence, the frequency of the disease in the community, but In secondary care, this is a higher frequency because it is better diagnosed, and obviously more in tertiary care, that is where we are. It represents as well 4 to 30% of the dementia cases in the population, and pathological studies show that the disease is approximately more or less the same, 10 to 25%. Parkinson's dementia, on the other hand, is approximately 10% of the Parkinson's population. And it does increase both of them with the progression of aging. So as we age, there is more possibility of getting these disorders. And this is of relevance because, as you can see in the estimates of how the population will age, you can see the population above 65 and those about 85 are the ones to truly increase in frequency in the years to come. Therefore, it is extremely relevant to know about these diseases and to prepare for them. So these disorders decrease the quality of life and increase caregivers' burden. And that is extremely relevant because we need to provide care not only to the patient, but also to the family. These are diseases that affect the family, not just one patient. And because they cause burden, the burden leads to 4 times more the placement of patients in nursing homes. The cost of dementia with Lewy bodies is much more than that of Alzheimer's disease, despite that the funding for research in dementia with Lewy bodies is much, much less. And all the cost is pretty much related to the caregiver burden that leads to the nursing home admission, and all that is due to the neuropsychiatric symptoms. And that is the major leading cause, and that's why it is more costly than Alzheimer's disease. Do we want to have an early diagnosis? Absolutely. Why is that relevant? Because if we provide an early and accurate diagnosis, we can treat patients appropriately. We can also be able to predict what are the complications of the disease and manage them and try to prevent them. We can also provide a prognosis, and patients can also participate in clinical research. We recently had a therapeutic trial. Now we do have a trial that is, or a study actually, that is to search for biomarkers that I'll talk at the end. So what are the characteristics of patients with dementia with Lewy body? Cognitive disturbances, psychiatric problems, fluctuations of this, both psychiatric and cognition, motor aspects, enacting of the dream, and problems with blood pressure and urinary disturbances. And I'll discuss one by one. So what are the problems with the cognition? Well, the important part is that is completely different than Alzheimer's disease. Here, the major problem is impaired executive dysfunction. And what is executive function? Well, it is our ability to plan, to multitask, basically what an executive does. But in addition, there are problems that are visuospatially. You can see here the difficulties that could be mild to much more severe that can be related to visuospatial disturbances and actually also executive dysfunction. But also there are problems with copying, for example, here pentagons or copying a cube, you can see how with the disease progression, the difficulty that people may have visuospatially. I said memory is not such a major problem. Well, it isn't. The major problem is what we call forgetfulness. Forgetfulness is the difficulty recalling spontaneously. Somebody call and you cannot remember spontaneously to tell your spouse that somebody called. But if the spouse asks you, did anybody call? Oh, now you remember. So you learn the information, but it's difficult to kind of bring it up. And as I said before, there are fluctuations. Some days in which you do very well, and some others in which that is not working well. And the remote that you could function well one day, the following day may be difficult. There are several motor problems, and I'll go over them. But just to start with, there is what we call Parkinsonism. And Parkinsonism is basically slowness or low amplitude of movements that can be associated with it, postural instability, with problems in resting tremor, or there could be some stiffness. But obviously, there are many manifestations of that. And so there is poker faces, such as loss of expression, difficulty with fine motor skills. And in addition to that, there is another movement that is myoclonus that I'll show you as well. So this is kind of what I'm referring to. Here, the amplitude of the movement, you can see the steps are very, very narrow as well as, or small, and there is no associated movements. I'm gonna show you here one of our patients who passed away and had this disease. And one of my first questions is about hallucinations, and I'll point to the issues that I want you to pay attention to. Is that scary for you in some ways?
No, that's sort of interesting. I'd like to see what's going on.
Okay. What are the interesting things you see?
Well, faces and colors and things that are attractive to me.
People that you know?
Yeah, sometimes, and other times people that I can't recognize.
Okay. So here is the myoclonus. This is kind of the jumping when we touch an extremity. And now you can see how the movements are going to be slow, the difficulty that there is in following directions.
Your nose.
And how small are those movements.
Let's do the right and then we do the left. Open and close, open and close.
There is lack of associated movements, and there is postural instability, there is a stoop posture, and lack of balance. Well, if we do a DAT scan, that is to look at the dopamine that is in the basal ganglia, that is the major chemical that have to do with the motor circuit and is what is really missing here, then we can see that rather than this lovely coma that you can see in a normal person, you can see that a person with Parkinsonism has the tail of that coma that is missing, and it could be asymmetric very frequently. This is not necessary for diagnosis. This is just supporting, particularly when someone does not have Parkinsonism, because Parkinsonism, as I show you, is a clinical diagnosis. So how we differentiate dementia with Lewy bodies and Parkinson's disease? Well, dementia with Lewy bodies, all these characteristics, the dementia, and as well as the Parkinsonian features do occur at the same time, or the dementia may occur earlier. But in the case of Parkinson's disease and dementia, first we have Parkinson's and the dementia comes years later. Initially, it is supposed to have a 1-year rule that separates those that have dementia with Lewy bodies from those that have Parkinson's disease and dementia. And this depends on the history that you tell your physician. This is an important sign, and this is what we call enacting of the dreams or REM sleep behavior disorder. When we sleep, we don't move. So there are movements when it's not in the REM, when we are dreaming. But when a person with Parkinson's or dementia with Lewy bodies dreams, they enact, as this person is doing, the movements. And so when the dreams are very bad, then you obviously try to defend yourself and can hurt yourself or your partner. There are problems of what we said is autonomic system, and that is the nerves that go to each of the organs. And so it is a problem with the blood pressure. The blood pressure when we stand usually goes up, but in case of people that have Parkinson's disease at later stages or dementia with Lewy bodies at early stage, the blood pressure drops. There are also problems with urgency to urinate or incontinence. And there are also problems with another test that is, we call it the scintigraphy. Normally, there are innervation of the sympathetic nerves that go to the heart. But in Parkinson's disease and in dementia with Lewy bodies, this does not exist. This does not mean that there are cardiac problems. This is just something that occurs and does not give any symptoms. So what is the criteria? It has what we call the core symptoms, the core features, the core characteristics. The dementia, that is with executive dysfunction, attention and visuospatial problems, the fluctuations, the visual hallucinations, the Parkinsonism, and the enacting of the dreams and the REM behavior disorder. And it is also indicative if we have doubts to add the DAT scan, the MIBG that I show you, or a polysomnogram that is a way to show the enacting of the dreams. How we differentiate dementia with Lewy body from Alzheimer's? Well, the dementia is different. The only problem is that at times, and it actually is frequent, that in the dementia with Lewy body, there is an associated Alzheimer's disease. But when that is not present, memory is not the issue. The issue are the executive functions, while memory, not recalling. So if somebody comes and somebody call and they said, who called? You have no idea if you do have Alzheimer's disease because you could not encode, you could not learn the information. The psychosis, the hallucinations are frequent and early in dementia with Lewy bodies, and if present in Alzheimer's, this is a late feature. Language is impaired in Alzheimer's and usually is normal in dementia with Lewy bodies, as you saw in our patient. The enacting of the dream, the REM behavior disorder, is frequent in dementia with Lewy body, but is not present in Alzheimer's or is as present as in the general population. The Parkinsonism is usually frequent and responds to levodopa, the dopamine when it gets to the brain, and is not present or infrequent in Alzheimer's disease. The myoclonus that I show you is frequent, is usually early, and is distal, as I show you, and is not usually present in Alzheimer's disease or maybe less frequent. The blood pressure dropping is a feature that is very, very frequent in dementia with Lewy bodies, but is not present in Alzheimer's disease. So there are several features that allow us differentiate it. So we do have a study, as I mentioned, that in this case is not for treatment, is to search for biomarkers. It may take a long time, and for some physicians that are not so aware, may take a long time to diagnose these people that do have this disease. Therefore, we're searching for markers, biomarkers. That is what Dr. Galasco will talk to you about, to try to diagnose a disease as early as possible, and also to use them to try to see when we do a therapeutic trial, if they change with time. So we do recruit people that don't have dementia yet, but have Lewy body disease, that is all the other features, but they don't have problems with, for example, functions such as shopping, driving, or things like that, or the driving in this case is unrelated to the motor problems. The dementia with Lewy bodies that I express, as well as the Parkinson's disease and dementia. And if you're interested, please call or contact Ashwarya, and this is on our website. So thank you very much for your attention, and I'm now ready for all your questions.
Okay, so far we have one question. This question is, you mentioned 1 year when discussing Parkinsonism and DLB. Could you please elaborate?
Well, this is somehow a little bit of debate in the sense that it is hard. This is put mostly as a way to differentiate these disorders. But as you can imagine, it's not exactly 1 year. This is very difficult. A biological thing doesn't, symptom problems do not occur like exactly 1 year and then 1 year after. But as a rule, it is very early, the dementia in dementia with Lewy bodies, and it's late or several years after in Parkinson's disease. However, once the dementia occurs, they are very similar. And when you look at the brain, when the person passes away, the changes are very similar. So if you look at the brain, you wouldn't be able to tell. And clinically, if you don't know the history, it would be very difficult as well. That's why telling all the sequence of events is something that we do carefully and is very relevant for diagnosis.
Okay, great. Now, there's a few people with hands raised. Are you able to type your questions in the question box? If you can, do that now. Otherwise, I'll get to you in 1 minute. There's a question from Nancy. Are people already diagnosed with Parkinson's disease and Parkinson's disease dementia able to participate in this DLB observational study?
Absolutely. Absolutely. That is exactly the point. So,
Okay, great.
yes. So please participate. It is very important to do so.
All right, next question. What are the similarities of LBD with tauopathies like CBD or corticobasal, frontotemporal dementia?
So there are not a lot of similarities, particularly because although the dementia may be similar, there are other things in these other disorders and that occur, like eye movement problems, eye problems related to what we call praxis, that is the difficulty kind of remember, like if you do know what you can do but you cannot really do it with your limbs, as well as problems in this patient population, the dementia with Lewy body, that is the low blood pressure that occurs when you stand up, the enacting of the dreams, and all these disorders that I mentioned that are autonomic, that really don't happen, except for the urinary problems that can occur, but it's not early. It's usually a little bit more late if they do occur.
Okay, we have time for just a couple more questions. Lee, do you have a question?
Maybe they cannot use their.
Yes, can you hear me now?
Yes,
Yes.
I can hear you.
Okay, I want to know how to treat the person when they're having these nightmares and thrashing about. How do you treat them? Do you turn lights on? Do you try to? I've tried talking, but it's like they don't hear me and they're very insistent upon what they have to do. And I don't know what to do.
Melatonin is a very good treatment for it, but Dr. Leger will discuss all this in detail. But melatonin that is over the counter, starting at 5 milligrams and going up to 20 is something that is extremely, extremely good.
The other question I have is my husband does not know he has Lewy body. Should he be told or not? My feeling is that it would absolutely shock him, kill him.
That's an excellent question. And this really depends on you and your family and how you know your spouse. Some people really want to know, and some people don't. And it's very difficult. In my view, it is better to know. But again, your cultural issues are very important. So
Okay,
Thank you.
Lee, I'm going to put you back on mute just so we don't have background noise. And just one more question for Dr. Litvan. Deborah asks, what level of blood pressure drop do you consider significant?
it's a good question as well. We consider 20 millimeters of mercury of the systolic blood pressure, that is the one that is on top, and 10 millimeters of the diastolic, that is the one that is below. That is, if you have, let's say, 150 over 80, and then you go to 150 over 50, that is orthostatic hypotension.
Okay, great. For the sake of time, I think we should jump into the next presentation. I am going to save the remaining questions for the end. All right, so next I just wanted to introduce Dr. Golasco. He's the director of the clinical core of the UCSD Alzheimer's Disease Research Center. He's a neurologist with extensive clinical and research experience in dementia, including dementia with Lewy bodies, and he practices in the Memory Disorders Clinic here at UCSD. Take it away.
Great. Thank you very much. And get the talk ready. So Dr. Litvan has set the stage and told you how we use ways that we test patients in the clinic to make a diagnosis of Lewy body dementia. There are exciting ways to try to use special sorts of tests or biomarkers to give us greater certainty, to maybe help us with early diagnosis and with new treatment opportunities. So before I talk about biomarkers, I wanted to talk about what's going on in the brain and in its connections in Lewy body dementia. So Lewy bodies are a collection of proteins that build up and form a clump in nerve cells. And they were named Lewy bodies by Dr. Friedrich Lewy, who identified them under the microscope in 1910. And this would have been what he was able to see, this pink circular object with a faint halo around it in a nerve cell. Under the electron microscope, we just see that it looks like an accumulation of all sorts of odds and ends. And it was not until the 1990s that we actually learned that a protein called alpha-synuclein forms aggregates or clumps within Lewy bodies, as shown here, where we now are able to take a brain section and stain it with an antibody against alpha-synuclein. And we find not only Lewy bodies, but we also find clumps within some of the projections. These are axons or the connections between nerve cells, and that's another example. And so this has given us a way to try and figure out where the pathology is and how abundant it is. This is a complicated slide. I won't go into all of the details, but a number of researchers have tried to come up with a scheme for how to stage Parkinson's disease and Lewy body disorders. And the idea is that the pathology seems to accumulate initially in Parkinson's in areas of the brain stem, which would correspond to movement problems and things like that. Interestingly, an area called the locus ceruleus in the pons is associated with REM sleep behavior disorder, which means that this could explain why this is such an early and often common symptom in Lewy body diseases. Over time in Parkinson's, the pathology can spread more widely to different areas of the brain that could affect thinking and could produce hallucinations and other kinds of symptoms. In DLB, we don't see quite the same progression. We see that there seems to be involvement of some of the cortical areas of the brain much earlier. And so unlike Parkinson's, where movement is such a common and predominant feature, in dementia with Lewy bodies, we often see these unusual symptoms of fluctuating alertness and different cognitive symptoms and hallucinations. So this is a schema of what might be going on over time. And if we think about certain kinds of symptoms or certain things getting worse, firstly, the pathology may be spreading from areas within the brainstem to areas in the cortex. And Dr. Litvan mentioned that a sizable number of people with Lewy body disease also have Alzheimer's pathology. And so while the Alzheimer's pathology is probably not going to contribute to things that are going on in the brainstem and not going to contribute to problems, it is going to contribute to cognition. So if we think about what may be going on at different stages, cognition can occur at different times of the disease. Motor Parkinsonism could occur early or a bit later. Autonomic changes could occur at different stages. And people can have genetic risk factors, which would be a way for us to try and figure out a subgroup of people who are at high risk. And then there may be changes in things like olfaction, losing the ability to smell things well. And then REM sleep behavior disorder can develop years ahead of any of the other features of Lewy body dementia. I've put in one biomarker here, dopamine imaging, as something that may appear early and change over time. And I'll show you this and other biomarkers as an example of how we might try to track brain pathology while people are still alive. So Dr. Litvan has mentioned the clinical approach to the diagnosis. And so this includes getting a good history, taking a history about how people are sleeping, are they functionally impaired? We'll test cognition, assess autonomic function, movement, gait, and balance. And then we'll try and put this all together and make our best guess clinically as to what's going on. Sometimes we see people very early at the stage of isolated REM sleep behavior disorder, which we are very interested in identifying. And sometimes we'll see people with what seems to be more diffuse Lewy body disease during either an early cognitive stage or actually at the stage of dementia. And Dr. Litvan had mentioned that there are these criteria that have been put together. And I'm not going to go through all of the details other than to talk about the principles. The principles are that to say that there is a dementia or similar syndrome, we have to characterize and emphasize cognition. We need to at all of these different kinds of clinical features, and they are diverse and involve thinking about not only cognition, but sleep, autonomic function, and so forth. And then there are biomarkers that can be used to try and gain greater certainty that we're dealing with a Lewy body disorder rather than something else. So biomarkers can be used to support the clinical diagnosis. And I like to think of these biomarkers in two different broad categories. Firstly, I've told you which sorts of brain regions are affected in Lewy body disease. And we can use biomarkers to try and tell us that these brain regions are misbehaving. And so I'll show you some examples. There are a number of different types of brain imaging studies. There's a DAT scan where we look at dopamine imaging, FDG PET, look at glucose utilizations, MIBG scan, Dr. Litvan showed you an example, brain MRI, amyloid PET scan for Alzheimer pathology. So these all give us all sorts of different maps of the brain. Importantly, we don't have an imaging test to be able to map alpha-synuclein itself. And so then there are other kinds of ways to try to approach what's going on. Can we identify the presence of abnormal proteins building up in the brain? And remember, we want to do this without actually drilling into somebody's skull and looking at their brain or taking a piece of it out. So we can look at cerebrospinal fluid. The fluid that surrounds the brain is accessed to us through the back by doing a lumbar puncture. And we can actually detect some interesting forms of alpha-synuclein. I'll show you some information about this. More recently, we've also been able to identify synuclein pathology on skin biopsies, which is very intriguing. And then we can try and decide whether someone has coexisting Alzheimer's pathology by measuring proteins called amyloid beta protein and tau. At the moment, these are done in spinal fluid, but there's emerging data to be able to do this using blood. So here is an example of DAT scans, and these have been around in Europe for many, many years, and they were approved by the FDA for a particular context for trying to diagnose Parkinson's. So we use them sometimes if we're trying to diagnose DLB. The idea is that this gives us an image of how well the substantia nigra, that's the area deep in the brainstem that is related to movement, how well those nerve cells send out projections to the next set of nerve cells in the pathway, which is called the basal ganglia or the striatum. And so this is normal. It looks like these two quotation marks. This would be asymmetric. There's a subtle degree of difference. Here's left and right, and there's a little bit of this lack of detail of this particular quote compared to that one. Here's a bilateral involvement where, again, these two quotes are lacking their tails, and this one's even fainter than that one. And here, they both are much, much more faint. So these are about 80 to 85% sensitive in Parkinson's and DLB, and they can even show abnormalities very early on in REM sleep behavior disorder. I'm not going to go through all of the numbers in this table and in the slide, just to show you that these were large-scale research studies that were done over 10 years ago. One was in DLB, and it turned out that we used diagnostic criteria to call people with probable or possible dementia with Lewy bodies. 80% had a positive DAT scan in this study if they had a probable diagnosis, 38% with possible DLB. With REM sleep behavior disorder, about 40% were abnormal. So these are not 100% tests for early diagnosis, but they give us some interesting data. FDG PET tells us how well the brain is using glucose. And for reasons we don't absolutely well understand, in DLB, areas at the back of the brain called the occipital lobe show a decrease in uptake of glucose. And one can use an index to measure occipital hypometabolism in DLB versus Alzheimer's. It's positive in about 70%, in some studies maybe a little more. And it's a little less sensitive or specific than the dopamine imaging I showed you, but still can be helpful. Amyloid PET imaging, I mentioned that Alzheimer's disease can coexist. Several studies have looked at this, and they have found that between 50 and 80% of people with DLB can have a positive amyloid PET scan. This is a brain map showing the usual sorts of areas where amyloid would be detectable with an amyloid PET. And this shows that in healthy elders, a certain number of people do actually develop amyloid and have absolutely no symptoms. In Alzheimer's disease, almost everybody develops amyloid with quite a high burden. With DLB, a percentage of people have amyloid with an intermediate burden. Does it matter if someone has amyloid and they also have DLB? There have been a couple of studies looking at this. This was a long follow-up study published from a group in Amsterdam, And in this study, they had obtained spinal fluid on everybody and looked at whether they could detect Alzheimer's disease in the CSF. And they used the mini mental state exam, which is a brief cognitive look at cognitive decline. And while there wasn't a statistical difference, it looks like the people with Alzheimer's are doing a little worse. When they looked at time to nursing home placement or the equivalent, this did have an impact on progression. So it seems like people who have DLB and significant Alzheimer's pathology may progress faster. And we're trying to come up with ways to treat Alzheimer's pathology, which would make this a very relevant thing to try to detect. So moving on, in the best of all worlds, we want to actually be able to say to somebody, you have something going on that involves alpha-synuclein, and the alpha-synuclein is abnormal. In the last few years, we've seen a really exciting breakthrough where it's possible to do something called a seeding assay for alpha-synuclein. And the idea is if one takes a sample such as spinal fluid, and this happens to contain a seed of synuclein, we put it in a little microplate where we're going to run the assay, and we add some normal alpha-synuclein. And now we shake this plate for 5 minutes, we let it rest, and we shake and we let it rest. The abnormal synuclein, this little seed, comes into contact with normal synuclein. At some point, it actually comes into physical contact and causes the normal synuclein to misfold. And this can be amplified. It actually takes a long time, 48 hours or longer, for this to happen at some scale. But eventually, enough synuclein is misfolded that we can detect it by adding a dye called thioflavin T, and we get a fluorescent readout. And so if you had a fluorescent detector that was monitoring all of this, it would show nothing for a very, very long time, a little bit of a reaction, and then very quickly a peak reaction. So how does this work? The initial studies were done in Parkinson's disease. And it was shown that about 90% or more of Parkinson's disease, and in one study, in this first study, a small number of people with DLB were studied, all had positive reactions, whereas people who did not have Parkinson's had negative reactions. And this is an example of what the data looked like. A tiny number of the Parkinson's had negative reactions. A few controls were positive. One of them actually later went on to develop Parkinson's disease. And then there are some follow-up studies. These are examples of what the actual reaction sort of looks like in groups of patients. Nothing happens for however long, 48, 72 hours, then you get a reaction. If someone doesn't have Parkinson's, we never detect a fluorescent reaction. So Nuclein-RT-QuIC is very exciting, and there actually is a company that is offering this commercially. It is not yet an FDA-approved test, and there is ongoing research to try and demonstrate its further utility. A number of other groups have continued to study this. This is an example of a very large study done by a group in Italy and one or two other countries in Europe. And they rounded up people, they obtained cerebrospinal fluid. They obtained people who were normal, some Alzheimer's patients, people with PSP, progressive supranuclear palsy, MSA. And here's DLB, Parkinson's, even REM sleep behavior disorder. And essentially, almost all of these folks had positive reactions. So it was detecting over 90% accuracy. Skin biopsies have been used for the same purpose recently. And the skin biopsy is usually taken either from the scalp or from an area close to the shoulders at the back of the neck. And the same principle, this skin sample is digested and it undergoes the same kind of amplification assay. If there are seeds of synuclein in the skin, there's a positive reaction. And this was a study published at the end of last year in which Parkinson's patients were studied. And as you can see, there's one positive in a control, and everyone was positive with one exception in Parkinson's disease. So these are both receiving a lot further study and are very exciting resources that we hope to be able to use soon. So in summary, at the moment, dementia with Lewy bodies and early stages of DLB, such as REM sleep behavior disorder, are diagnosed clinically. A comprehensive assessment of cognition, movement, sleep, and behavioral symptoms is required. And I hope I've convinced you that biomarkers can support a lot of different things. They can tell us whether synuclein is likely to be present in the brain or not, and whether Alzheimer's disease is also present. Some combination of biomarkers, including brain imaging and CSF or skin biopsy, is very helpful to us, certainly on a research basis and getting closer and closer to the clinic. So thank you very much, and I'd be happy to take some questions.
Great, thank you. I'm going to read a few questions for you. The first one is, do all LBD patients have REM sleep disorder?
The answer is no, not all, and we don't know why. Some people don't develop REM sleep behavior disorder throughout the course of Lewy body disease. It is common, probably 30 or 40% of people at least do have it at some point.
Okay, great. Another question, is myoclonus related to hyperreflexia?
Dr. Liffman could answer that as well. The answer is not necessarily. We think of the myoclonus as being some sort of disinhibition of movement and movement control. And while it sometimes could be associated with brisk reflexes, that doesn't have to be the case.
Okay, two more questions. This one, are the spinal fluid and skin biopsy tests being used regularly now for diagnosis, or just still being tested?
So they are still in research mode. Neither one is FDA approved. The skin biopsy tests have only really been looked at in the last year. There's tremendous excitement, and we are hoping to try and make these sorts of things available within another year or two.
Okay, great. And one last question before we move on. Is it helpful to leave your brain to the movement disorder clinic?
So actually the Movement Disorder Clinic and the Alzheimer's program both have brain donation programs. And the answer is we are interested in carrying out research on people who donate their brains. For us, the most useful are people who donate their brains who we have a huge amount of data on, especially research data with biomarkers and all sorts of other things during life, so that we can try and match things up.
Okay, great. So I'm going to save the rest of the questions for later. Thanks so much, Dr. Glasgow. Next, we'll have Dr. Legere, and he is a board-certified neurologist who specializes in Alzheimer's and related disorders, including dementia with Lewy bodies and Parkinson's disease dementia. He's working to expand patient care at UCSD by developing a new multidisciplinary memory disorders clinic. And are you ready to go?
I am. Thing. Everybody see my screen properly?
Looks good.
Thank you. I have to start with an apology, and that is that I tend to use the word Lewy body disease rather than dementia with Lewy body. So you'll see the three letters LBD versus DLB inverted in most of my slides. A bad habit that I got during residency, I think. I also want to say what a privilege it is for me to speak with both Dr. Litvin and Dr. Glasgow. I've learned from the textbooks that they wrote, so it really is quite a pleasure and a little bit of a daunting task to speak after them. That being said, I'm going to talk a little bit about the treatment of Lewy body disease, at least how we do it practically in our clinic currently. Well, first things first, treatment of any neurodegenerative disease begins with basics. And this is something that I tend to put at the end of our after visit summary for all of our patients, regardless of the cause of their disease. And these are basic brain healthy habits. And they actually, we believe, and there's growing data for this, that paying attention to the health of your brain and your general health as a whole, that you can slow down these processes. And by brain healthy habits, we mean regular aerobic exercise, eating well, and by that we generally mean the Mediterranean diet or some version of it. We talk about the management of vascular risk factors, things like diabetes, cholesterol, and hypertension, managing these aggressively. We talk about social engagement, being involved, engaging with people and friends and family, using your brain, as it were. We talk about sleep and how important that is and doing everything we can to improve the sleep-wake cycle. Sometimes people ask us about over-the-counter medications and sleep aids, and I'll say a few things about that. But in general, we try to avoid sedatives and recommend medications like melatonin. In Lewy body disease, there's other considerations that I'll talk about. If you have problems with hearing, there's accumulating data that hearing loss is associated with cognitive decline. And so if there are any issues with hearing, we tend to send people to the audiologist and treat if it's appropriate. And finally, we look for ways to reduce stress. Dr. Litvan pointed out the sort of 5 pillars or 5 core criteria that are clinical criteria that are involved in the diagnosis of Lewy body disease: cognition, fluctuations, Parkinsonism, REM sleep behavior disorder, and hallucinations. I'll be addressing these more or less individually in the rest of this talk. There's a couple of things I'd like to say about cognition. This has sort of been looked at already, but the difficulties in cognition in Lewy body disease are different than the ones for Alzheimer's disease, and they really center on attention, visual, spatial, and executive functions. And I'll show some examples of that and how we can help that. Sometimes the fluctuations, and I'll say a little bit more about this later, but fluctuations can sometimes lead to behavioral difficulties. That can lead to people being treated with certain types of medications called neuroleptics or antipsychotics. These are anti-dopamine medications. People with Lewy body disease are extremely sensitive to these medications, and in fact can do very, very poorly if they're given. So it's something to keep in mind whenever a patient with Lewy body disease is having difficulties with behavior or is coming into the emergency room and is being treated. Keep in mind that these patients are very sensitive to these medications, and sometimes doctors forget about this and give these medications anyway. You can be your loved one's best advocate by reminding them about this sensitivity. There are a number of other issues that are not part of this triad, this pentad, including orthostatic hypotension, constipation, excessive daytime somnolence, agitation, anxiety, and depression. These are all things that we can sort of address, and I'll be mentions of that in the next few slides. Again, just to point out how different the difficulties can be, the cognitive difficulties can be in Lewy body disease. These are 2 patients, one with Alzheimer's disease and one with Lewy body disease, trying to copy the pentagons, and for the case of the Lewy body disease, trying to copy the box. And they have the same degree of impairment. They both score about the same on the mini mental status examination, the MSC, a score out of 30. Very early disease in both, but look how terrible and how difficult it is for the patient with Lewy body disease to copy the intersecting pentagons. Dr. Galasco mentioned that the alpha-synuclein, the Lewy bodies, tend to involve more and more areas of the brain, and that cognition at some point becomes more obviously impaired. When does that occur exactly? There are various points in time, but when the basal forebrain, that's this area here in the front, and the base of the brain here becomes involved, the nucleus basalis of Maynard. When this area becomes involved, cognition tends to be much more affected in Alzheimer's, in Lewy body disease. This is just a cut through this part of the brain to show us this area where the main cells lie in the basal forebrain. The cells that lie here are acetylcholine cells, cholinergic neurons that secrete acetylcholine as their neurotransmitter. That's relevant. That's the neurotransmitter that's affected in Alzheimer's disease. And it turns out in Lewy body disease, it's also quite affected. In fact, it's affected more than it is in Alzheimer's disease. And you can see that from this kind of graph where we've measured the number of cholinergic neurons within the basal forebrain. And as you can see, dementia with Lewy bodies and Parkinson's disease dementia are much more affected than Alzheimer's disease, and obviously controls. Why is that relevant? Well, the treatments that are available to treat Alzheimer's disease were designed to counter this drop in cholinergic neurons. The three main medications that we use in Alzheimer's disease are rivastigmine, galantamine, and donepezil. Exelon, galantamine, razidine, and Aricept. And it turns out that these three medications are actually very helpful in the cognitive difficulties associated with Lewy body disease. In fact, there's an improvement in overall cognition relative to placebo of over 30%. Patients that receive this medication are often less anxious, they have fewer fluctuations, they have reductions in hallucinations and nighttime behaviors. The improvement on the MMSE is actually higher in patients with Lewy body disease than it is in Alzheimer's disease. There's been some concern that using agents that increase cholinergic transmission might worsen Parkinsonism, but that's not the case in these patients, and that's been studied. Improvement in these aspects of deficits, and these deficits lead to a reduction in caregiver burden. It also turns out that these medications are very well tolerated in Lewy body disease, even at much higher doses than we can use in Alzheimer's disease. One of the main side effects of these medications is diarrhea, which helps reduce the constipation that's often present in patients with Lewy body disease. Here's a small graph simply showing you how much more significant the improvement can be in the mini-mental status examination in patients with Lewy body disease relative to Alzheimer's disease. Here's an example of a patient of mine this is his clock before I started treating him, and this is what his clock became after he was started on donepezil. So moving on, I'd like to talk a little bit about hallucinations now. I don't know if any of you know, I think all of you know about Alice in Wonderland, but maybe not many know about Marvin Peck, who was an illustrator and a playwright at the time of that Alice in Wonderland was written. And he contributed many of the images contained in this one of these original editions. Here's another example. This is a self-portrait of Marvin Peck and another picture of a person wearing a dunce cap. A dunce cap meaning that the cap that you give to people who are not behaving very well. I think this picture is very interesting. It depicts a little bit some insight that he had. Let me show you some of the hallucinations that he was experiencing. So the hallucinations associated with Lewy body disease include often little people that casually walk around the house, animals, cats, dogs that can also sort of hang around the house, sometimes ghosts of deceased people sitting at the bedside, or objects that can be suspended in unusual locations. One example that I heard recently was bicycles hanging off the branches of trees. Typically, at the beginning of the disease, these are not very frightening. The patient often has insight, as I mentioned, and are aware that they're experiencing unusual visual phenomena. But as the disease progresses and the insight is lost, it can become very disturbing. I have one patient who won't go to bed because he sees or hallucinates somebody in his bed already. It turns out that these hallucinations actually respond fairly well to the cholinesterase inhibitors. There are other medications that we can try, but I find that using cholinesterase inhibitors and increasing the doses the best approach, at least initially. I mentioned neuroleptics, the antipsychotics or antidopamine agents. It's the first reaction that I think physicians have when somebody is hallucinating or having psychotic, what we call a psychotic episode. And it's the first thing that we want to do is give them this kind of medication, but it should really be avoided, especially early on, in great part because patients with Lewy body disease are so sensitive to these medications. This is the brain stem and the area where Lewy bodies first start accumulating in the brain anyway. And there are sort of three pathways of dopamine transmission. It's transmission through the mesolimbic and mesocortical systems here in this sort of basic area of the brain, and the frontal area of the brain that leads to the behavioral and behavioral problems and hallucinations. In patients with schizophrenia, for instance. The mesostriatal pathway, this one here, is the one that's involved in movement. So in Lewy body disease, or in Parkinson's disease in particular, it's this area of the brain that's involved most, and it leads to the movement disorder associated with Parkinson's disease. Treating the hallucinations in patients with Lewy body disease is an attempt to block the system that's overactive in patients with schizophrenia. In Lewy body disease, of course, it's underactive, and so it actually causes more problems than benefits. So the use of typical antipsychotics in patients with Lewy body disease should always be avoided. There are atypical antipsychotics that are not as severe, that don't tend to affect the movement disorder areas of the brain. Quetiapine is probably the best example and probably the one with the least amount of impact on this part of the brain. The brand name is called Seroquel. And it turns out that this particular antipsychotic, atypical antipsychotic, is better tolerated than all of the others, but only at low doses, usually not reaching more than 120 milligrams a day or so. And at these doses, they don't tend to worsen the Parkinsonism. Unfortunately, they don't actually help out with the hallucination and the agitations that much. Maybe a little bit, and occasionally we do reach for that when use of the cholinesterase inhibitors hasn't worked. There's another medication that's been publicized and has been, in fact, approved for the treatment of psychosis and hallucination in Parkinson's disease, and that's Nuplazid. It works by a completely different mechanism. It affects serotonin receptors. It has not been approved for the use in other disorders other than Parkinson's disease. We do reach for it occasionally as well as a last resort in Lewy body disease. But I've found it to not be that helpful, unfortunately. And this medication, although it's not an antipsychotic or an anti-dopamine agent, it is still associated with issues with cardiac arrhythmias, and like neuroleptics, it's associated with a reduction or an increased risk of death. Let's talk about, I apologize, the Parkinsonism now. So as we mentioned, the Parkinsonism develops when this particular pathway is affected, the pathway leading to the basal ganglia. Now, the treatment that we usually use, and Dr. Litvin can speak about this at length as being an expert, but the treatment of choice for patients with Parkinson's disease is levodopa. It's the precursor to dopamine, the medication, the neurotransmitter that's lost. In Lewy body disease, it can be helpful, but at the cost of worsening of visual hallucinations and psychosis, increased agitation, and can also cause increased daytime sleepiness. At very low doses, we can sort of get away with treating the movement disorder itself, but at higher doses, we run into problems. Typically, doses beyond 300 milligrams a day start causing more problems than benefits in patients with Lewy body disease. There are some studies showing that the addition of zonisamide, that's an anti-seizure medication that's actually been approved for the treatment of Parkinson's disease in Japan. The addition of zonisamide to levodopa allows for better control of the movement disorder, the the slowing movements, the rigidity, and the tremor that come with Parkinson's disease. Can help this and help lower the required dose of levodopa. I don't have very much experience in that, but I think it's something that we'll be looking at more and more. Next, let's talk about the fluctuations. The fluctuations in Lewy body disease can be quite striking. Patients often talk about changes in alertness or zoning out. Excessive daytime sleepiness can be a form of fluctuation. There can be confusional spells. The fluctuation can be so severe that people can seem like they're stuporous or nearly unconscious or unresponsive. Their speech can become very incoherent. Patients can become agitated. And of course, all of these changes may look like delirium. Delirium is a medical condition that is actually considered an emergency. So often when these things occur, particularly if they're dramatic, patients can end up in the emergency room. And sundowning, something that I think probably all of you have heard of, is a form of fluctuation. As I mentioned, the fluctuation can be so severe and lead to things such as stupor, and often mistaken for stroke, leading to visits in the ER. I've had some patients with Lewy body disease who have actually had treatment for stroke, TPA, and recovered, of course, but that was exposure to treatment with unnecessary risk. Patients with most dementia syndromes will experience fluctuations. It includes Alzheimer's disease and vascular dementia. But in Lewy body disease, it's much more prevalent, much more severe, and in fact is one of the 4 criteria for diagnosis. And it's present in one in 2 patients at the time of diagnosis. As I mentioned, fluctuations can appear a little bit like delirium, and so it's important to rule out medical conditions that can lead to delirium, such as a bladder infection, constipation, again, something that's very common in Lewy body disease, sleep disturbances and sleep apnea, anemia, and any kind of organ failure, such as kidney disease, heart disease, or liver disease. Toxicity from drugs can also lead to delirium and fluctuations. So it's important to rule out these issues as well, or we simply attribute the fluctuations to the Lewy body disease itself. But use of antipsychotics can lead to fluctuations or delirium. Use of benzodiazepines, and the typical medications that we think about are Ativan, Xanax, and Valium. Use of these medications can complicate the picture of fluctuations. And use of anticholinergic or drugs with anticholinergic properties. And this is a very big culprit here, Benadryl and medications like it, that are often used to help calm people or to help with sleep, are actually associated with worsening fluctuations and worsening outcomes in patients with Lewy body disease and all dementias, it turns out. The fluctuations can be very prolonged, lasting days or weeks, but most of the time they're actually pretty quick, and you can actually see them during an examination. This is an example of simple reaction time. In a reaction time test, you hear a beep and you press a button. And as you can see, a patient with Lewy body disease, their ability to respond to the beep can vary from one full second to 2.5 seconds. And with time, their reaction time can vary quite a bit. This is an example of somebody with no fluctuations down here. As you can imagine, if you're fluctuating like this and you're trying to think, you might have, as you're heading down, as you're heading up one of these, having more and more trouble focusing or thinking, you might think that it's difficult and you might experience this problem, and especially if you have insight. So this can lead to people with Lewy body disease actually saying things like, I don't know, I was about to say it, but I can't remember what I was going to say, or I'm having trouble getting the words out. Very common complaints of patients with Lewy body disease. I'm bringing this picture back only because you can actually see some of the fluctuations here. The patient was asked to draw the intersecting pentagons with a felt tip marker, and as they fluctuate, you can see the ink from the felt tip marker sort of bleeding into the paper as they experience their fluctuations here. I'm showing this picture again only to re-emphasize how Marvin Peck must have felt as he was experiencing some of these fluctuations and feeling not as smart as he usually is. The first approach to treating fluctuations is non-pharmacologic. Really try to fix the sleep-wake cycle, and I find that in emphasizing exercise and exposure to light during the day and being very active during the day and keeping a nice routine, going to bed at the same time and getting up at the same time is a good way of helping reduce fluctuations. As I mentioned, antipsychotics should really be avoided because they can actually worsen the picture. But there's some evidence that very low dose quetiapine and as an adjunctive agent, the use of valproic acid, so combination of valproic acid and quetiapine together might actually reduce some of the fluctuation. In my experience, again, cholinesterase inhibitors are the most effective agents at reducing these fluctuations. And certainly that's the information I get back from families when these medications are started. I want to mention two other types of agents. This is not in the context of the fluctuations, but simply moving on. Namenda is one of the medications that's used to treat Alzheimer's disease. It blocks glutamate receptors. Glutamate is the main excitatory neurotransmitter in the brain. And Namenda helps to modulate its effects and reduce some of the toxicity that too much excitation can sometimes cause. The use of Namenda in Lewy body disease has been studied, and to some extent, it's not as dramatic as the effect of cholinesterase inhibitors can be. But there is a global impression of improvement when Namenda is added, and behavior is also improved as measured by a scale called the NPI. Serotonergic agents, or SSRIs, selective serotonergic reuptake inhibitors, they fall under this broad category of medications we call antidepressants, are actually very helpful as well, particularly in reducing the anxiety and the frustration that people with Lewy body can feel. And I bring back again this self-portrait of Marvin Peck, and how frustrating it must be experiencing these sort of downturns in thinking. These medications can improve, some of these medications can improve sleep, and others can improve wakefulness. These are a list of some of the medications that I reach for most often. And depending on their side effect profile, I'll use one or the other to address some of the issues that are present. I'm not going to show this. You've seen this video already. Only now to talk about REM sleep behavior disorder. REM sleep behavior disorder is a core clinical criteria for Lewy body disease. And as Dr. Litvand mentioned, during sleep, the body muscles are usually paralyzed. This is what we call atonia. In Lewy body disease, the part of the brain that allows this paralysis to occur is actually damaged. So the atonia that's present in REM sleep is lost, and that leads to acting out of dreams. This often precedes the diagnosis by decades, and so we actually consider it a good biomarker or marker of disease, of preclinical disease. It's present in most patients with Lewy body disease, often at the time of diagnosis. Up to 65% of patients with Lewy body disease will have RBD that we can extract. My first approach is to try to help modify the sleep environment. Some patients have sort of taken this into their own hands. This is a patient of the researchers who first reported the existence of REM sleep behavior disorder. He fell out of bed multiple times and developed this kind of technique. He attached a belt to his waist and an elastic band to the bed to prevent him from falling out. Of course, the bed partner can be injured as well. And so often people with Lewy body disease will sleep in beds that are separated, or two single beds put together rather than one king bed or queen bed. It turns out that one of the better medications to treat this REM sleep behavior disorder is a benzodiazepine. Now, I said that benzodiazepines should be avoided in patients with Lewy body disease, except for clonazepam or Klonopin. Somewhat of a magic bullet. We don't really understand why, but it's extremely effective at reducing REM sleep behavior disorder at low doses, 0.5 to 1 milligram. In some patients, I've gone to higher doses, reaching up to 2 or even 2.5 milligrams. As I mentioned, this is an atypical benzodiazepine, but we do use it. It can cause drowsiness and falls, so it's something that we need to be careful about when the patient gets up a lot, if the patient gets up a lot to go to the bathroom at night. And it also can worsen sleep apnea. Again, something that we want to make sure that we know about if it's there, or diagnose it if we don't know yet, and treat it appropriately before we can use medications such as clonazepam. Very effective, though, against REM sleep behavior disorder. I tend to go first, though, before using clonazepam, I tend to use melatonin, which is also very effective, maybe not quite as much as clonazepam, but it does reduce significantly the REM sleep behavior disorder. Melatonin is a hormone that's produced by the pineal gland, and we actually secrete less of it as we get older. It helps regulate the sleep-wake cycle, and for some reason it tends to reduce REM sleep and the expression of REM sleep behavior disorder. Just a few notes about the future. The disease-modifying therapy, there's a lot of activity to try to find ways to prevent the disease or to slow it down. The Lewy body, as Dr. Velasco pointed out, is the telltale of a synucleinopathy. There are attempts to prevent the synuclein toxicity by the use of antibodies against synuclein. These would reduce them from the brain or prevent their spread. And there are agents that prevent misfolding of the protein, agents that promote its degradation, and agents that can also reduce inflammatory changes that are associated with it. These are all things that are being considered or in clinical trials currently. So in summary, the 5 pillars of the diagnosis of Lewy body disease are all domains that we actually can address with medications and with interventions. And I believe that that we can really make a difference in how patients progress with how the disease is expressed and reduce caregiver burden. I didn't talk about orthostatic hypotension specifically, but there are also medications for that if that turns out to be a problem in a particular patient. That's all for me.
Great, thank you. Let's answer a couple of questions and then we'll start the film. Let me get to these questions. First, is CBD something to use?
We tend to stick to medications that are FDA approved. I get myself in trouble whenever I try to answer these questions about other medications. I won't prescribe it myself. Of course, it's available in many other ways without a prescription. And I do have patients who use it and who say that it's very helpful at reducing anxiety or promoting sleep, or even increasing appetite in patients who might have weight loss and appetite and loss of appetite for other reasons. But I do try to manage these other symptoms with the medications that I talked about beforehand. That being said, the patients of mine who've been using it have found it to be very helpful and they swear by it.
Okay, great. Another question. What are the most common anti-dopamine drugs to be aware of or avoid when managing fluctuations?
Yeah. So the first, I think the first one that patients often receive in the emergency room is Haldol or haloperidol. It's a very, very potent antipsychotic medication. And if at all possible, you should write it on the list of medications to avoid. If you will, I'll make my slides available, and I'll include a list of the common ones that are used. But I'm thinking of medications like Thorazine. Zyprexa is a medication that's an antipsychotic that's considered an atypical, but it turns out to actually be fairly potent as well. And I think patients with Lewy body disease are more sensitive to that one than they are to the Seroquel. I'll come back to this point, is that if there's any antipsychotic that needs, if you absolutely need an antipsychotic, Seroquel is the one to go with.
Okay, and one more question related to treatment. Do you recommend magnesium L-threonate for those with LBD?
I don't. I think maybe I'll have to do some research. I wasn't aware of the use of magnesium or L-threonate, but yeah, my answer is no because I don't know about it, but I will look that up.
Okay, we'll follow up on that one. Okay, thanks so much. Now I'm going to share my screen, and we're going to watch the film called Spark: Robin Williams' Battle with Lewy Body Dementia. Wow, that was a very powerful movie. I thought any of our speakers want to just wrap up or say anything in summary before we move on to the Q&A.
It was very powerful. I think you're absolutely right. Very emotional. And I think they describe how he changed in a way that was unrecognizable for him as a person, and how the delusions and likely also hallucinations had taken him, how many fluctuations he had. At times he would realize what's going on, at times he wouldn't. And the fears, he wouldn't get out of the house. But he was such a loving person, such a generous person, and that I don't think he ever lost. It doesn't look like it, but everything else he did. I think that his level of cognition was so high that probably took some time for him to be diagnosed. But certainly the lack of knowledge, I agree, is something that probably was a major factor for not being diagnosed, and the relevance of diagnosing early. I think it avoids a lot of cost of care, burden for not knowing where are all these symptoms coming from. So I think couldn't be shown in a better way.
I also wanted to bring up that the material that we're dealing with and that we are showing in the film is really tough stuff. I think a lot of emotions come with that, especially if you're dealing with it in real time, either with yourself or a loved one. But despite that being tough, I think there's always opportunity to make life better and bring in joy. And I hope that this virtual event today at least brought more information. We hope that knowing what we're dealing with is the first step to better care, future cures, treatments, all of those things. So I hope that we can still instill hope after this kind of tough material. Dr. Glasgow, Dr. Legere, do you have anything you'd like to add?
So one comment I would make, I mean, one of the things that came through in this was Dr. Bruce Miller, for example, talking about, the brain being devastated, a number of other things. I mean, I think that for all sorts of reasons that we may never fully know, Robin Williams really sadly had an incredibly severe case and very widespread pathology. And his age at onset was in his early 60s, which is young for Lewy body disease. And so putting all of those together, it makes us understand the kinds of symptoms he went through, and the tragedy that if they were diagnosed and managed, things would have taken a different turn. I think, this is an extreme, there are many extreme features of this case, and it doesn't generalize to everyone with Lewy disease. We don't want everyone who's tuned in today to think, gee, in no time at all, synuclein is going to be running rampant through the brain. Everybody is different, and a lot of symptoms and things are manageable. So I'd like to put that perspective onto it.
I think I would echo that as well, that every patient is very different, and what we do in clinic to try to help them is a form of personalized medicine. And his disease was particularly quick, I think, probably because he had such a great intellect and was probably compensating to a great extent, especially because he had conserved insight throughout the whole process. I think that he was able to compensate until really it was too much, when things finally started breaking down visibly to others around him. And I think that, I mentioned insight throughout my part of the talk, but he was really, really hard on himself. And I think if it had been possible to have him and his wife understand that this was in fact a disease, it might have helped a lot. I think we could have brought much more happiness to the many years that he suffered from this. And that also opens the door to discussion about mental illness as a whole, even if it's not from neurodegeneration. But when it is from neurodegeneration, we can say this is what's going on. There's a reason he's acting this way, because there's something going on in his brain. A little bit like you can't blame a child, as Dr. Miller said. You can't blame a child for doing things for which their brain isn't capable of doing yet. The same thing applies to.
And you need to consider as well that he was not treated. Mm-hmm. So I think the lack of treatment is what made this so hard. So one, the lack of diagnosis that made them have so many testing and being so burdened. Is this schizophrenia? Is this dementia? He didn't know. He knew there was hallucinations and delusions, because otherwise he wouldn't have asked about this. But the fact is, he didn't have the diagnosis, that is very hard, and also no treatment, that is also very hard. And I think that's why, as well, made this so much of a tragic ending.
Of course, there's no cure, but I think we believe that treatment can make a big difference in the many years that people deal with this, if only in terms of education, but also in terms of alleviating a lot of the suffering that occurs for both the patient and the caregivers.
Well, I want you to know as well that there is information in the Association of the Dementia with Lewy bodies, and also that we do have in our website. So I want you to know that it is very important, particularly if you know people that do not know about this disease, to really make them understand, and that there is really information available. But I'm ready for the questions, I think, if there are any.
Yeah, one quick thing I wanted to mention, in my follow-up email to the people registered, I can be sure to highlight some of the resources about Lewy body dementia, so don't have to worry about jotting that down. So we are over time, but I hope if we can all hang out a little bit longer, we can get some of these questions answered. The first one I have here, you mentioned language being intact in DLB or Parkinson's disease dementia. That said, I have experienced a handful of people with Parkinson's with either DLB or PDD who no longer have intact language. Is that a function of dementia, oral apraxia, or something else?
Well, the thing is that at times, as I mentioned, there is the association of dementia with Lewy bodies with Alzheimer's disease. And in these cases, the language is significantly impaired. But in general, there could be decrease of spontaneity in talking, but the language is usually very spared. And people can talk as Robin could and express a lot of what he felt. So that's the majority of people. But the association with Alzheimer's is frequent as well, in both, in Parkinson's disease with dementia and much more in dementia with Lewy bodies.
All right, next question. My husband has been diagnosed with Parkinson's. His brother has Parkinson's with Lewy bodies. Is there any explanation why one and not the other?
Well, that is hard to say. There are different genes that may affect one person and not the other. There could be at times duplications of the gene for alpha-synuclein and triplications that make the disease much worse. So there is duplications that may cause Parkinson's and triplications of the alpha-synuclein gene that cause dementia. There are many variables that are very hard to explain, and genetics would help. And there is many other things that we need to be looking at to try to disentangle what the problem is.
Okay. The next question I have, what other dementias is REM sleep disorder associated with?
Well, REM sleep behavior disorder is also associated with multiple system atrophy, and it is associated with Parkinson's disease. So it precedes all these three diseases. It precedes Parkinson's disease, it precedes dementia with Lewy bodies, and it precedes multiple system atrophy. It is much more frequent in Parkinson's and dementia with Lewy bodies. And the distribution is hard to know exactly where each person goes. So there are symptoms that are common initially, but then obviously they differentiate afterwards.
Okay. Next question I have, is it correct that someone with Lewy body dementia will not respond well to dopamine agonists like Apoquin?
No, it's not true. We don't use Apoquin in general because it lowers the blood pressure, and it's a strong medication, and it doesn't last long unless there is a pump. But levodopa is a much better medication. It doesn't lower the blood pressure as much, and has equally or better benefit.
Okay. Next question. If the presence of amyloid with LBD accelerates cognitive decline, doesn't that suggest that amyloid is causative in dementia rather than a result of the disease? Chicken or egg issue?
So there's a big debate about amyloid. We think that amyloid is necessary for Alzheimer's to happen. Whether it directly causes Alzheimer's and dementia, or whether it indirectly causes it by stirring some other things up, and these other things are the much more direct cause, is being debated a huge amount. I personally don't believe that we can simply ignore the presence of amyloid. It's just complex to figure out. If we try to remove it, is that going to completely stop everything, where the answer seems to be no? If we remove amyloid, can we have some sort of impact? And the answer is maybe. And then we don't understand why in some people, what looks like an Alzheimer amyloid process also seems to kind of, I'll use the word, stir up alpha-synuclein aggregation.
Okay, great. How many people with Parkinson's also get Lewy body dementia?
Well, it depends at what time, and it depends also of many other factors. we could say that in general it is 10%, but if you are older, if you have a very severe Parkinson's, if you have many years of disease, the frequency increases in significant ways, and it can get to 80% at times. So it truly depends, and also depends on the genes. There are genes that cause the Parkinson's and the dementia, like the GBA at times, the GBA gene, but there are other genes that don't, and so on and so forth. So there is many variables, and so it is very hard to say for a one person exactly what it is, but it would be easier in some ways, perhaps, than the general population. But overall, it's 10%.
Great, thank you. Are there any recommended approaches to try and calm or reassure someone who's having a major hallucinogenic episode or who wakes from a very bad dream believing it to be real?
This is a hard one. But yes, I think that it's important to kind of help calm the person down and bring up the reality, but not fight. There is no need for fighting. So if the person, I think that fighting doesn't help.
And I think I would add too that emotional response is really at the core of that. So our first instinct is probably to tell people that's not real, this is what's happening. But sometimes it's just addressing that person's scared or anxious or whatever the feeling is behind that manifestation, and that might be helpful. I'm so sorry you're feeling this way. That sounds very scary. Those kinds of statements may be helpful, but there's no magic bullet for that.
I would say that also, obviously there are medications that we use when these sorts of things happen, and we do try to minimize their impact. But when it does happen, just whether because we haven't started medications yet or despite the medications, I think, yes, an approach that's comforting, that's calming, that's not confrontational, will go a long way. Frequently people with Lewy body disease may wake up from a dream that they were acting out and have a lot of difficulty separating out reality from the dream that they just woke up from. And that can be very, very scary. And it might be hard. You might think, oh, I have to wake them up and make sure that he or she gets out of this state. And that may not be the best approach. One might be just to continue calming and to continue trying to diffuse things. Everybody's different, and many of the approaches that any one person will take will often depend on the kind of relationship that they had to begin with, and often discussion with our social worker or with our nurse or with our physicians to explore, how these things happen and what exactly was going on can be helpful as well.
Certainly, you need to let your physician know, because otherwise you're not going to be treated. So it's extremely important to make your physician aware of the symptoms.
All right, I think we have two more questions. This next person writes, I was diagnosed with LBD last year at 54 years of age. I have experienced definite language difficulties, struggling for words or using the wrong word. For example, library when I'm at post office. My brain knows what I want to say, but the word I speak comes out different. Is this a sign that something else is going on in addition to LBD?
Well, I think that this is less likely to be an dementia with Lewy body presentation. I can't say for sure, but I think asking for a second opinion would be a good thing.
All right, and then I had one more question in the chat box here.
I might add to that, that as was sort of discussed in some of the talks, that there is often co-pathology. So it's not unusual for more than one process to be taking place. At 54, typically there's only one thing going on, but as we get older, there can be additional Alzheimer's disease, Parkinson's, or Lewy body diseases, or even vascular disease. And the idea that you can have more than one thing going on needs to be considered. I think presentation of Lewy body disease as a whole is, if you think about it starting somewhere and then progressing to involve other parts of the brain, that path, that trajectory where different parts of the brain gets involved is different in different people. And so it's possible sometimes that attention is more affected, or maybe the language areas might be a little bit more affected, but typically you're right. It's not something that we see as a criterion or something that's very obvious about it.
Okay, and one more question. If you have multiple first-degree relatives who have Lewy body dementia, but you have no current prodromal symptoms, could you be considered a research subject or a healthy control?
So the answer is possibly. It sounds like with multiple people in the same family with this sort of diagnosis, there may be something genetic going on. Usually our approach or our recommendation is, if there is going to be genetic testing done, we would start in somebody who has symptoms. And if there are, family, it would be useful to have a family discussion to discuss who might want to be tested, why they want to be tested, so forth, which physician, maybe genetic counselor, will handle the testing and help to get the result back. If you don't personally have any symptoms, you might have inherited a gene that puts you at risk, but you might not. And we usually don't start off by testing somebody like that. So, this certainly does raise the possibility that there are genetic factors. I would say start off with some of the affected family members, assuming that people within your family can have a discussion about this, and find a physician with some expertise in helping you coordinate the genetic testing.
Okay, great. I think that's all of our questions.
Well, I want to thank all of you. I think that is extremely important to know about this disease and diseases in general. We want to learn a lot before buying a TV. We need to learn a lot when someone has a disease so we can understand it and we can prevent it and treat it. Thank you so much. Prevent the symptoms. No, we cannot prevent the disease in this case, but prevent the symptoms in some way or treat them extremely early. So I want to thank you all for staying with us for so long, and I wish you the best. Have a wonderful weekend. It was a tough start though.
Thanks so much. Please email me with any questions. Bye.
Bye.
Right.